Hello everyone, welcome to Med Adventure. In today's episode, we'll be having a discussion on a case report published on Annals of Internal Medicine Clinical Cases. Before moving to the discussion, I would like to mention that this video summarizes a published case report. I do not claim authorship or credit for the original case. Patient details have been de-identified and this is not a medical advice. Now, let's move to the discussion. The title of the case report is An Unusual Cause of Acute Abdominal Pain, a case report and review of the diagnosis reasoning. The patient in the case report is a 63-year-old man with history of severe peripheral vascular disease, type 2 diabetes mellitus, hypertension, excessive alcohol use, and diverticulitis complicated by colovesical fistula, and repair was done 1 year ago. He presented to the ED 2 hours after he experienced acute abdominal pain. It was sudden onset, generalized burning pain of the abdomen. On physical examination, the patient was in moderate distress, afebrile, hypertensive, and abdomen was distended, and hypoxic bowel sounds were heard. The abdomen is also diffusely tender. On laboratory examination, there was no leukocytosis. However, creatinine was elevated as well as lactate. There was also microscopic hematuria. On imaging, CT angiogram was done and there was no aortic lesion. Mesenteric vessels were patent. However, there was ascites. There was no free air and no new pathologies was seen in the kidneys. Then, the patient was admitted and repeat non-contrast abdominal CT was done, which showed contrast leakage from anterior wall of the bladder, and contrast was also seen in the ascites. This confirmed the clinical diagnosis of spontaneous bladder wall rupture. Urology site was consulted and bladder was repaired and patient was discharged 4 days later. Now let's have a brief discussion on the differential diagnosis considered in this case. The first differential diagnosis is bowel perforation. Signs of peritonitis and elevated lactate levels support the diagnosis. However, there was no sign of free air, which was against the diagnosis. The second differential diagnosis considered was ischemic bowel or mesenteric ischemia. Elevated lactate levels and patient history of peripheral vascular disease supported this diagnosis. However, patent mesenteric vessels seen on CT angiogram and early onset of peritoneal signs were against this diagnosis. Abdominal aortic rupture or AAA was also considered as a differential diagnosis. Elevated lactate level supports the diagnosis. However, the presence of stable vital signs was against it. Signs and symptoms that supported spontaneous bladder rupture were the onset of abdominal pain starting after urination, a history of bladder surgery, and new onset ascites. Before we conclude this discussion, let's have a few words on bladder rupture. Bladder rupture is relatively common in a setting of acute trauma. However, in contrast to trauma-associated bladder rupture, spontaneous bladder rupture is rare. Patients usually present with abdominal pain, abdominal distension, ascites, hematuria, and elevated creatinine level. For more information, I recommend you to go through the case report. Thank you guys for watching this episode. Hope this case report has been interesting. Please don't forget to like, share, and subscribe for more.